that this place this morning was one of the poorest and had a knife cut. I was in Cuba on government business, whether you like it or not. I was there on government business because the law allows me to go there. And I remember calling my CEO and telling my CEO, I have picked something that I do not like, and I want you to make sure that by the time we get to Nairobi, I see the file. Because what was on the social media was then that a patient did not stay for 24 hours and was charged almost 1 million shillings. And I said, that is, of course, obnoxious by all standards, even if the child is Magoha's son, because...
Very good evening to you. Welcome to The Big Story. So tonight's conversation is one that touches on every single Kenyan. Whether they're rich or poor, young or old, it's about healthcare. And it's a conversation that several Kenyans have been having today on social media. And it would be interesting, it would be important that we all take part in this conversation because it affects our lives, all of us, in one way or the other. So, a meeting to discuss proposals to slash hospital fees by 70% was held today in Nairobi. The Medical Practitioners and Dentists Board held hearings to collect views from the medical stakeholders and the public on just how much a doctor should charge patients as consultation and how much a hospital should levy for procedures. Should all parties agree, then patients will be charged less for expensive services and procedures. It means that, for instance, the maximum a hospital can charge for cesarean section procedure will be 60,000, down from the 180,000 that some hospitals are currently charging, specifically private hospitals. So all this came about from that story that we all knew about. That story happened, I think, in April last year, and it touched on a young lady called Matilda Anyango. So this is what happened. Matilda sustained injuries after a botched robbery attempt, and she had knife wounds. So she went to Mpisha Hospital, and she stayed there for less than 12 hours, and her family got a bill of about 858,000. And there was such an uproar. And that is why the conversation that was being held this morning was being held to just have a conversation about the cost of health in the country. And as we begin this conversation, I would like to bring in my colleague, Dr. Mercy Korir. Mercy Korir is joining us from Kenyatta National Hospital. Mercy, good evening. This is an important conversation that we all need to have. And I know there were guidelines that were stipulated 2006, 2013, and 2016. But then opinion is divided. Could you take us through how we got here?
Okay. Well, Linda, and it's good that we have Dr. James Nyikal, who will give a more detailed perspective of the 2006 guidelines, which is where we started this conversation, where the doctors' fraternity came together and sat down and gave guidelines where there were minimum charges and maximum charges for several procedures, including even the consultation fees that you talked about, dental services, and also the medical practitioners' services. And the medical practitioners is from the medical officer, the general practitioner, that is all the way to the consultants. Now, in 2013, these guidelines were reviewed again, and in 2016, they were reviewed again. And this was just factoring in that the cost of living definitely has been changing over time. Definitely inflation has an effect to all, it affects all of us, and doctors are not immune to this. So these guidelines were changed, and it is what the document that we have today. And these guidelines were gazetted as the 2016 guidelines for doctors to charge patients. And take note that these are the private doctors' professional fees. Of note is that in the public sector, there are no professional fees charged for anyone seeking healthcare services in the public sector. They would go to a hospital, open a file, and they should get all the services that they are seeking in the hospital, and especially if they have a cover like NHIF cover. Obviously, that's a whole other conversations because of all the deficiencies and inadequacies in our health system, but ideally they shouldn't be charged anything else. So these particular guidelines are for the doctor's professional fees. Now, the hospital fees or the institutional fees are a whole other discussion. Most of us, when you go to any private hospital, some people who go to private hospitals will probably pay a consultation fee. Let's say when they go to an outpatient department or an accident and emergency department to see the doctor, this consultation fee is to see the doctor, yes, but that is payment to the hospital. It's not what the doctor takes home at the end of the day. So there's all these differentiations. So the discussion today is on these professional fees that I, as a doctor, will charge for consultation, will charge for a procedure. If I'm an obs-gyn or an obstetrician gynecologist, how much can I charge as the minimum for a cesarean section, for example? If I'm a dentist and I'm doing a root canal, what is the minimum that I can charge? What is the maximum? What is the consultation fee? So this was the discussion, and or rather this is what brought us here. Now, the case that you referred to, Matilda, she went to the A&D at MP Shah. She was attended to, and the family got this bill of 800 and something thousand, almost $1 million. And the public opinion was that this fee was just too high for somebody who didn't even stay for even 24 hours in a facility. But when the case went to the medical board, who is the regulator, and they looked at it, and from the assessment, they said that the hospital and the doctors are charged within the guidelines. But then the question is, yes, maybe within the guidelines, but can your patient or can the patient afford these fees? And this is why now this discussion, or there was a conversation today convening the stakeholders to come and discuss, from the civil society, from the law society, from religious organization. We had the COFEC, which is Consumer Federation of Kenya, who also were part of the people who convened the meeting. There were people from Maendeleo ya Wanawake. We had people from Bunge la Wananchi, from various parts of the country. There are just Kenyans of goodwill who are coming to be part of this conversation so that they can put their voice into this whole conversation about reducing the doctors' fees. Now, remember, Linda, that on Saturday, the doctors' fraternity, led by the union, KMA, and the other professional bodies held a meeting, and they said that they had given their input to the medical board about the user fees, and they were not going to attend this meeting today. And true to that, they did not attend the meeting.
Mercy?
But in their previous discussions with the medical board, they had discussed and decided that the compromise they would arrive at is to reduce the maximum chargeable fees by 20%.
Okay, Mercy, listen.
And that is now the position that was presented today. Yes,
Mercy,
Linda.
I know you're talking about goodwill, and I know you have Dr. Omar Oluga with you. Is he anywhere close to you? Maybe you can pick his mind?
Yes. Actually, I was just going to go there because in the internal stakeholders meeting that the board had with KMA and KMPDU, where they discussed and decided to have these user fees reduced by 20%, this was taken as the position of the doctors' fraternity. And now today they were missing, but then their opinion was taken into consideration. And after all these deliberations now, we want, and I had been discussing with Oluga earlier just to find out from him, and he will tell us if, in their opinion, they think that these fees, the doctors' fees, are either high or moderate, or are they adequate? And what are we basing all these user fees on? Because at the end of the day, Kenyans are feeling the pinch of having to pay that fee. So Dr. Omar Oluga is here, and he'll be able to tell us, what is this fee based on? Because Kenyans are complaining that this is just too much.
Thank you very much, Mercy. For the record, I think speaking on behalf of the union, the Kenya Medical Practitioners Pharmacists and Dentists Union, I want to categorically state that for us as a union, we have been very clear in championing for a publicly funded and a publicly run healthcare system. So on that note, I want to say that this discussion is a bit unfortunate. It's unfortunate because out of the 48 million Kenyans, the Kenyans who go to private sector are just about 2 million. and that is about 4%, because they are the Kenyans who have insurance, or somehow their companies or they have employment, and their employer can pay for them. So, and this is, it's actually a show of how we as a society can be very discriminate to the very poor people in this country. Because if 96% of this nation, 96% of citizens in this nation cannot even go to private sector, that means that they would never be able to go to a doctor, even if you reduce the fee for professional fees. For example, let me use cesarean delivery. If you reduced it, right now the minimum, as per the board, is 90,000. If you reduced it, for example, by whatever percentage to even 50,000, how many people can afford that? And secondly is that doctors don't even charge those fees in the first place. So it's unfortunate that we are being driven by commercial interests. And I want to say these commercial interests are people who have been sponsored by the insurance companies, because the question you must ask ourselves is, who benefits when the fees are reduced? Matilda's case, may God rest her in peace, is one example that even if they were to be charged 100,000, they would never be able to afford that. And that's the situation for many Kenyans. So I want to say that that's unfortunate we are discussing this. Having said that, we as a union and as representing the doctors, I want to state very categorically that what we need to do as a country is to discuss the whole spectrum of cost of healthcare. And the cost of healthcare, if you really are to be serious about discussing the cost of healthcare, you wouldn't be talking about the professional fees for doctors. Professional fees for doctors in this country and in many countries is it's around number 5 or number 6 in the things that are expensive. The things for this country, the number one cost is corruption, because in the corruption then there's a lot of value chain. And I'm talking about private sector. I'm not talking about public sector. Even in the private sector, there's quite a bit of corruption that makes, you know, for example, you go to a hospital, any private hospital, and the markups are quite huge. And those markups are quite huge because some company had been given a contract to supply at whatever price, which is twice or 10 times the price that they would actually buy it for. You know, and then the second thing is cost, hospital cost. The third thing is taxation. The fourth thing is transport cost. Then professional fees come. So even if Kenyans were to be discussing professional fees, and for us as a union, we are very much willing to engage in the cost of healthcare, including the professional fees, but you cannot come and start talking about professional fees alone. And that is our stand. So even the opinion that was presented today, I think that was a suggestion of the board. And as much as doctors do not have enough opportunity to really put their input, I think we need to review this whole discussion and this whole guidelines for professional fees, because the absolute truth is that also you really cannot dictate what a professional can charge. That's the absolute truth. But if you want to lie that we can, then let's do some job that resembles people who are serious.
But the thinking for Kenyans, or among many Kenyans, would be that if you have all these building blocks that go all towards the cost of healthcare, and professional fees is one of them, if you're discussing professional fees, then why not discuss and dispense with this so that you can just move to the other issues? Because yes, truly, at the end of the day, they still need to be discussed and to be dealt with.
Yeah, that is quite true in terms of the feelings. But I'll tell you again, go back to the question of who really benefits when you discuss professional fees in isolation. The person who benefits is not actually the consumer, and it's not actually the patient, because as I mentioned to you, there are about 2 million Kenyans who have insurance. So if we're going to reduce professional fees, there are two people that are going to benefit, the insurances and the hospitals. Why? The hospitals, first of all, they do not even pay the doctors, and the insurance also, they do not even pay the doctors. So what happens is that the hospitals, they have been charging this professional fee. So for example, if you go to a hospital and you get, again, I'll use something that's very common, a cesarean delivery or a cesarean section, and the hospital charges you 90,000, for example. There are some hospitals that have actually employed their doctors. So you find that they charge you 90,000 a professional fee, but at the other end, they are paying the doctor a salary, or they will never even pay that doctor the 90,000. And the same thing happens with insurance companies. So there are a number of things that we have to put into consideration before we discuss the professional fee. So I think the thing is that it's being rushed. For us as a union, we want to engage. The way forward, if we want to discuss cost of healthcare, is, and by the way, I've talked about this before, this country needed to do what is called a pricing policy. So if you do you can do pricing policy for various sectors, but there can be a pricing policy for healthcare, where you talk about the pricing for drugs, the pricing for equipment. And if you do a pricing policy, then you have to look at the environment, you have to look at the market, you have to look at the consumer power, you have to look at the tax regime. So we cannot, and I want to say this categorically, I think the people who introduced this discussion are misleading us. And for us as a union, we are not going to allow ourselves to go into blackmail. And if this kind of things continue, I think we as a union are going to engage directly with the 96% of the Kenyans who want public health sector to be working, because that is where we need to be discussing. You know, the idea that I should be able to afford a private doctor, that it should be affordable, is already discriminatory. It means that we are not taking healthcare as a right, because there are many people in this country who cannot even afford 100 shillings. Even if you said that to consult a doctor, we will reduce it from 2,000 shillings to 100 shillings. There are many people who cannot afford that. So I think for us and for me, we are not going to enter into this kind of piecemeal discussions. But if we have to really discuss it, then let Parliament be serious. And we are going to do a petition as a union. Let them do a pricing policy. And the pricing policy has almost 10 components. And that's what we're going to be doing as a union.
Okay.
Yeah.
Thank you very much for your time. Linda, as you can see, well, the opinions are diverse, and you'll find out even from the discussions as we go on with the big story that the opinions still are diverse, and probably more time, and stakeholders need more time to sit and really come up with a consensus that at the end of the day benefits you and I as the end user of the health services. Linda.
Mercy, opinions are so diverse, you have no idea. You need to look at the social media and the conversation that people are having there just to know that we're not going to get to the end of this anytime soon. Dr. Masikori, thank you so much. Speaking to Dr. Ouma Oluga, this is a doctor's show, and Ouma says you can't talk about professional fees alone. This resembles blackmail, and we can't have piecemeal discussion, and we need to look at pricing policy as well. So let me bring in the guests we have in studio. This evening we have Dr. James Nyikal, member of the National Assembly Health Committee, and he's also the member of Parliament, Seme. But for the purposes of this conversation, we are speaking to him as a member of the National Assembly Health Committee. This rests heavily on that particular committee. We also have Dr. Jackie Kitulu. She is the President, Kenya Medical Association. Lady and gentlemen, thank you so much for joining us on The Big Story this evening. Dr. Nyikal, let me begin with you, because you signed the medical guidelines of 2006 on medical fees, and COFEC is, of course, proposing that the 2016 rates are cut down by about 70%. And you've listened in to Dr. Ouma Oluga. Where do you stand in all this, first of all?
Well, I think the issue is you have to look at the fee guidelines of 2006 and what is the history behind it. This actually was at a time in this country when, again, the private sector was being run to a large extent by a new system that was being brought in of managed health care. And what was happening is that instead of the insurances as we know them, where the insurances actually pay when patients have been seen in hospitals, here we had bodies that were coming in, were collecting money, and at the same time treating people, so that they'll collect money as an insurance, but also provide services and then pay for those services from the money they have collected, which if you look at it immediately, you find that's a big problem. You can't collect money and then you treat the person, and then what is saved is your profit. Of course, then you are motivated to keep as much of it as possible. So the problem, the crisis we had at that time is that these organizations, the managed care organizations, were actually at a big war with private doctors, not public hospital doctors. And so there was need to put a guidelines that if then they are going to get doctors to see the patients, and then they will pay from the money they have collected from patients or a pool of patients, and then there need to be a guideline. And that is really what motivated the production of that guideline, so that the issues between these managed care organizations and the professionals would then have a basis of discussion. That was really the basis of that. However, the need for fee guidelines, as you can see, was necessary at that time, and therefore, when they were revised in 2013 and 2016, finally, it looks like now it was seen as the fee guidelines that is to be charged in the private sector. And as Dr. Lucas rightly said, this is referring to fees that are charged by private doctors when they're in private hospitals or in their clinics. This is totally different from the charges that the patients that are levied on the patients when they are, for example, in mission hospitals that employ doctors. There you will not have a distinction of, say, this is a doctor's fee. They will have a charge for the care that have been taken, which will include what they'll pay the doctor's salary, which will include the drugs that they use, which will include the investigation that they do. So that is really the background. Now it is coming out as if this is the main cause of high health care. If you look at it, the truth is, if you go to a hospital and in some hospitals, not all, some private hospitals, the doctors come in and see the patients and they levy their charges. And so if you look at the list, the cost that a patient will get, and you look at the list of the charges that are there, you will find that the doctor's fee is probably something like 10 or 15% of the whole fee that the patient is going to pay. Therefore, the argument that we are having now is really not exhaustive, because it is looking at one element of the cost of care or the fees that a patient will be faced with. It is leaving out the cost of the drugs, the cost of the bed, and if in ICU, the cost of the ICU, and if there are procedures that have been done, these procedures are not included. So really, what people should look at, what is the cost of care? And this will be important even then in the public health facilities. Because if you look at the cost of drugs in general, if you look at the cost of other inputs, if you look at the inpatient, then you now know this is what healthcare costs.
Okay.
So this argument, as much as it is, to me, it is useful because it is drawing the country to look at what is the cost of healthcare. But I think it is being narrow. What should we look at? Even in the private sector, what is the total cost and what does it comprise of? And then when you want to discuss, in my view, discuss all those. I would say personally that the doctors, as leaders in the profession, really may take part in this, but I think they should not be the focus, because that focus does not help anybody because it's dealing with a very small portion. But as leaders in the profession, they can say, okay, let's look at our guidelines that if you want, and then this is for a small proportion of the people in the country who use the private sector. But then look at what is the cost of the drugs, what is the cost of the bed in the hospital, what is the cost of the procedures. If you're in ICU, what is the cost of ICU itself?
Right.
So that is what we should look at, the cost of health care in the country.
The overall cost of healthcare.
Exactly.
Dr. Kitulu, what are your thoughts?
Thank you very much, Linda. And I really appreciate this opportunity to be here to engage in this discussion and actually put to the public with clarity what the issues are. Now, I think I would like to start from the onset by declaring that when you read the Constitution of Kenya, it guarantees you the highest standard of healthcare. So on whose onus is that? It is the government of Kenya, the Ministry of Health, the governors of the various counties. That is where the responsibility lies. And where do they then administer that responsibility? That is in the public hospitals. So I would like to state that from the onset, because that's the discussion we should be having. Where do we in terms of the cost of healthcare, where are the costs to the majority of the public? Now, that put aside, of course, there is the private sector in health, and the private sector in health will, in addition, be part of the health system. And in that system, offer part of the services that the public health system will not be able to offer. I would like to go to the point of looking at the cost of healthcare and looking at the drivers of cost of healthcare. And the number one issue that we should focus on here, for that patient who has had an accident and is brought into a facility, what is the number one reason that they will have an issue that they cannot afford this care? Because then it would be that a public service is not functioning. So lack of a functioning public health system is the number one cost of, high cost of healthcare. And when we are talking about then that, why then is it a high cost? Because you go to this public facility where all of us went as children. That's where our vaccinations were done. That's where treatment was done. My teachers, Dr. Nikal, who's here in studio, those were my seniors, they said the best facility was a public facility.
What happened?
That is where you had the best consultants, where you had the best services, the teaching was going on. Why have we let that come down? So you have now patients who go into a public facility, and the reason they will not seek services there is quality issues. They're not getting good quality. There are not enough health workers. I mean, you have you have few doctors, few nurses with a huge contingent of patients. The laboratory services are not working adequately. Even where facilities have been built, you find, yes, there is a theater set, there is a neurosurgeon deployed there, but then they cannot do head surgery because there is no ICU, or the consumables for ICU are not available. So you're looking at costs of healthcare coming around because of the public health system not working as it should be. And I'll go back to my first statement, the onus of that is on the governor. Make that system work. Once you make that system work, then in terms of the private sector, the cost of healthcare there will be sorted by market forces. We must agree we are in a free market economy, and the forces in the market control the costs. If we sort out the public healthcare system and that each and every one of us can walk into a facility, wherever we come from, be it Machakos Hospital, maybe Kenyatta Hospital, even the health center closest to us, that if we can walk in there and get good health care, then we are not forcing the public to then go out of pocket and seek care in the private sector. In the private sector, there is choice, that those who will want to go there and pay a little more, they will pay. And that choice is displayed in so many sectors in this country. Sectors of essential care. We're talking about the education system. We have free public education. But why are some people not taking their children there? They're finding it's a quality, that there are too many students, the teachers are struggling. So we are going back then to saying that, in essence, in this discussion, and I'll reiterate what Dr. Nikal has said and what Dr. Oluga has said, that we are diverting the discussion to a portion of cost of healthcare that is only just a fraction. So that if we are having this discussion, what we should be having is a sober discussion on what is the total cost of healthcare. That discussion will serve the public, will serve the private sector, will serve each and every Kenyan. Because in that case, then we can look at what is driving cost. It's the cost of medications. Then let's, part of the Big Four agenda is saying promote manufacturing. So then promote local manufacturing, so manufacture drugs, reduce cost that way. We are saying reduce, if you're talking about the issues of hospitality, the issues of what is the cost of transport, what's the cost of electricity, all those things add up to the cost of healthcare. Of course, then we must also address the cost of the professional fees in the private sector, but not making that the priority over the cost that would involve the masses of the Kenyans.
Daktari, so basically, yes, we are having a conversation, but it's not the right conversation. What we are discussing is a fraction of what the problem is.
Absolutely. This whole conversation has been diverted to a fraction and losing the big picture. The big picture being that, yes, our government is responsible for ensuring that we have a fully functional health system, a public health system. And that goes back actually even to the Big Four agenda in affordable healthcare.
Okay.
UHC was rolled out on the 13th of December, and we applaud that effort. Being tax funded, that the taxes we pay go into that healthcare and in the public facilities. That we applaud, and that's what we should be focusing on. How do we make it work?
All right. We're going to continue with this conversation on the big story, but right now allow me to take a short break. We'll be back.